vitamin E, and caffeine. In fact, this last case, the lower incorporation efficiency, here we also intend to better observe the role of the nanocarrier itself regarding the skin penetration, as I will explain you. Starting with the methods of this work. Here it is the formulation of these three preparations. We had just 1% of the active, 10% of the lipid, which was soybean phosphatidylcholine, SPC. We tested two different surfactants, 30% of ethanol in ethosomes and transethosomes, and purified water as the main vehicle. Starting with the preparation of transfersomes, quite easy. We just add all these components, and this mixture was stirred for at least 1 week, just that. Ethosomes were prepared according to the classic method, in which the ethanol and lipid mixture is stirred and immersed in a water bath at about 30 degrees. After obtaining the complete dissolution, we had the water drop by drop through a syringe needle that we insert here in the bottle cap. And as we had the water, we could also observe the formulation changing its colors as the vesicles are being obtained. We stir for more 5 minutes, and after that, we just kept this formulation at room temperature. Regarding transethosomes, those were prepared according to these two different methods. Method A, corresponding to transfersomes, and B, to ethosomes preparation. And at the end, all these three formulations were filtered under nitrogen stream using this filtration device that you see here, and using a polycarbonate membrane that we put here in order to obtain that vesicle size. Now, regarding the characterization of these vesicles, we start to observe the morphology of the vesicles by transmission electron microscopy. We measure the size and zeta potential by dynamic light scattering and laser Doppler anemometry, respectively. We calculate the incorporation efficiency and active entrapment yield inside the vesicles after the separation of the incorporated active fraction by ultracentrifugation. Then we assayed the active compound by HPLC system and the lipids using a commercial kit. We have also calculated the flux and elasticity of these vesicles according to these equations, and also using the same filtration device, but now with a smaller pore size membrane. We have measured viscosity, because this was for topical delivery at these conditions. And finally, we have performed the topical delivery studies according to official guidelines. And according to that guidelines, we must use France diffusion cells. So we just applied here in the donor compartment an infinite dose of the formulation and under known occlusive conditions. And we have also ensured that here, down in the receptor phase, we have sink dissolution conditions. Then, at certain periods of time, we collect the receptor phase and assayed by HPLC in order to evaluate the releasing profile, if we put here in the middle a synthetic membrane, or the permeation profile, if instead we put just skin. And finally, we have also evaluated the penetration into different skin layers by the tape stripping. So, the results of this work, starting with the macroscopic appearance. As you can see, transethosomes were the most translucid formulation. And curiously, with electron microscopy, it was observed the same, including the presence of multi-layers and also the spherical form of these vesicles. Now, this huge table is just to show you how important it is in research lab to standardize all procedures, since the formulation, composition, preparation, and even characterization methods, in order to better compare all these related formulations. Starting with the size. Our main goal was to obtain 150 nanometers, and we have obtained that except for certain formulations of trans-ethosomes, especially those prepared by the transfer-small method, perhaps due to a higher steering period and also a better rearrangement of the vesicles components. That's why we decided to use the trans-ethosomes prepared only by ethosmall method for the topical delivery studies. Regarding the polydispersity index, this should be the lowest as possible in order to indicate that we have an homogeneous population. And that's exactly what we have here, except in one formulation, transfersomes with vitamin E, in which it was a little bit higher, perhaps due to the specific location of vitamin E inside the vesicles membrane, and also to its higher incorporation efficiency. Regarding the zeta potential, the charge, it was negative, as expected, attending to the formulation's composition, and the highest values were obtained for sodium cholate formulations, because this is a negative surfactant. And also the higher values indicate a higher stability, considering that there is a higher electrostatic repulsion between vesicles. And in this case, the actives did not influence this parameter. Now, regarding the active entrapment yield, it was higher for vitamin E than caffeine, as expected, attending to the lipophilic nature of this vitamin, which could be easily incorporated in the vesicles membrane. On the contrary, the hydrophilicity of caffeine will difficult its incorporation into the aqueous internal space. And finally, the viscosity was quite suitable for topical delivery, being a little bit higher in the presence of ethanol, because this will fill the voids of the hydrogen bond and then fortifies the structure. And the vesicles flux and elasticity. As you can see here, trans-ethosomes were more deformable than ethosomes than transfersomes for both vitamin E and caffeine formulations, including the emptying controls. Finally, the topical delivery studies, starting with the releasing profile with formulations with vitamin E. As you can see here, the order was exactly the same as observed for the flux of these vesicles. Why? Because trans-ethosomes are the most deformable vesicles, so a higher membrane passage and active release would be expected. However, the same did not happen with formulations with caffeine. In this case, the releasing order was exactly the opposite, probably because this is more related with caffeine solubility, which was higher in transfersomes, and thermodynamic activity rather than in UDV deformability. And it was also observed a higher release for solution controls of each UDV. In this case, we have also tested the solution controls attending to the low incorporation efficiency of this active. And the skin penetration here, the first graph is in the stratum corneum, and the second one in epidermis and dermis. So as you see, trans-ethosomes contributed to the highest amount of the skin penetration, as expected, attending to the highest releasing and deformability. Again, the same did not happen with UDV with caffeine. In this case, we have also observed a higher skin penetration of those solution controls. So here you can see we proved that these nanocarriers did not improve the passage of the known incorporated fraction of caffeine through the opening transitory skin pores as the UDV passed through the skin compared to the solution controls, perhaps due to the absence of lipids in that solution and lower viscosity and higher caffeine solubilization. Now, the skin penetration of these UDV were also confirmed by fluorescent confocal microscopy. And in this case, we incorporate some dyes in this UDV. So as you see, we have obtained a successful UDV penetration into different skin layers here, and also the cellular uptake. And these vesicles were localized around the nucleus of keratinocytes. Now, regarding the therapeutic applications, here I represented the in vivo studies of tretinoin and lycopene-loaded UDV. According to this histopathology of mice skin treated with tretinoin-loaded UDV, the irritation potential of this formulation was much lower than the commercial formulation. You see here some signs of skin inflammation, which were not present in tretinoin-loaded UDV. And the therapeutic effect of the drug was still maintained, as observed according to epidermis proliferation. And we have also evaluated the therapeutic effect of lycopene-loaded UDV, which was in this case demonstrated by the inflammation caused by anthraline. And besides this inhibition, it was also inhibited the sebaceous gland's hyperplasia. Curiously, that hyperplasia was still here after the corticosteroid treatment. So a very nice result with lycopene and also tretinoin in these UDV formulations. Now, regarding dermocosmetic applications, nowadays there are several companies that are investing in nanotechnology, especially L'Oreal. And why? Because these nanocarriers, including lipid vesicles, have different functions in formulations. Besides being nanocarriers, they can also stabilize these formulations. So we can have several cosmetic and dermatological applications depending on the actives that are incorporated in these vesicles. Most of products in market are liposomes, but there are also now new products with etosomes and transfersomes. And finally, this last slide is just to show you the huge number of nanomaterials that are used in cosmetic products, including cyclodextrins, solid lipid nanoparticles, crystals, among others, besides lipid vesicles. So the conclusions are UDV are useful as topical and transdermal delivery systems, besides contributing to improve technological drawbacks and increase the therapeutic index, as we have seen for tretinoin and lycopene. And they are also useful for dermocosmetic applications. Among them, transetosomes are the most deformable vesicles, perhaps due to the synergistic combination of ethanol and surfactant in their composition. So they are suitable for a deeper skin penetration, but only with a high incorporation efficiency, as we have seen for vitamin E. So the future perspectives of this field, I think it will pass through hybrid and synergistic systems in which we combine them to achieve several applications. Also, a new generation of textiles which incorporate these nanocarriers, and also the expansion of the study of new nanomaterials to reach the market stage, and finally, update, and this is very, very important, to complete the regulatory issues, mainly nanotoxicology issues. This is very, very important. So thank you very much for your kind attention.
The session is open for questions if anybody has. Thank you, Dr. Andrea Asens. Any questions? Yes.
Osteoporosis is reduction of bone strength. Why is it so important? Because about 10 million people in the United States of America suffer from osteoporosis, and 48 million people suffer from osteopenia. That means weakness of the bone. That's a sum of 58 million people. This slide demonstrates the change that aging and medication makes the bone fragile and porous. Osteoporotic fractures occur in 1 to 3 women throughout their life, and 1 in 5 men. And it occurs about every 3 seconds worldwide, and 2 million per year in the United States. It's a very, very big sum of the patients, and a lot of suffering is done. This is another picture showing what happens to the bone by aging. It's a silent disease. The problem is that no symptom until there's a fracture. People can suffer from kyphosis and loss of height by the aging, and this slide demonstrates what's happened to the spine. Microfractures occur in the vertebral spine because of osteoporosis. This X-ray demonstrates the wedge fracture and loss of height in the vertebral spine. Some are asymptomatic. You must take an X-ray. You can find it in normally walking and working people. WHO considers it the second global healthcare problem, and I'm sorry. This came out. The chance of dying from cancer, breast cancer, is equal to osteoporosis for a woman over 50 years of age. That's interesting. Nobody cares about osteoporosis, but women care a lot about breast cancer because they can feel the suffering. Why is it so important? Hip fracture leads to deep vein thrombosis and pulmonary emboli in up to 50% of the cases. 20 to 40% of hip fractures don't come back to their normal life, and they need long-term care. That means it's a very, very devastating and serious problem to have a hip fracture. This is a normal curve of bone. It starts at birth. We have a rise in bone density and bone mass until about 40 years of age. And regardless of the condition, after 40 years of age, decline starts. Any insult on this curve will lead to a lower bone density, like oophorectomy, the blue line, or people who have hypothalamic or nutritional problem don't have the peak bone mass, and when the peak bone mass declines, the fracture occurs earlier. Osteoporosis, drug-induced osteoporosis, the most common drug is steroid. Cyclosporine, in the field of rheumatology, actually 2 drugs are the most used and problematic drugs are cyclosporine and steroids. Cyclosporine usually is prescribed with steroids. There's no good study to evaluate the function of cyclosporine individually as an agent that induces osteoporosis. But we must be careful when we prescribe cyclosporine. Glucocorticoids inhibit osteoblasts, stimulates bone resorption, impaired calcium absorption, increased calcium loss, urinary calcium loss, and suppresses adrenal and testicles and ovaries. And at foremost, myopathy increases the chance of falling down and the chance of fracture. There's a rapid decline of bone density in the first 3 months. The first 3 months is a very critical time for treating patients. And it's followed by a steady state of bone loss with continued use. We can have increased risk of fracture with even 2.5 milligrams of prednisolone for 3 months. And the population that already has a risk of fracture, a small insult in the bone mass will result in an earlier fracture and death. The association of risk fracture and use is a cumulative dose. The cumulative dose correlates with the risk of fracture. New fractures occur up to 70% after 1 year of steroid therapy. 30 to 50% of people on chronic steroid have asymptomatic fractures. Although it's a very important health issue, management remains suboptimal to multiple studies, and patients are undertreated. Timing is the most important issue in treating these patients. Steroids may help bones in some way. Pro-inflammatory responses can be blocked with steroids. These pro-inflammatory responses induce osteoporosis. But the balance of steroid use in rheumatic patients leads to osteoporosis. The help is much lesser than the harm. The mechanism of why osteoporosis is induced is incompletely understood. What should we do? We should work on prevention. Patients with high risk of fracture needs treatment, and patients who will be high risk during the course of treatment should be treated. The gold standard is to take a dual energy X-ray absorptiometry or DEXA scanning from the patient to evaluate the bone mass. WHO has developed a method of measuring bone density. It is comparison of the age of 30, that means peak bone mass, with the current condition. It is defined as with how many standard deviations there's a difference. If we have a 1 standard deviation difference, it's not a matter, it's considered to be normal. If we have more than 1 and less than 2.5 standard deviations, it's considered osteopenia, that means weak bone. And more than 2.5 standard deviations, lesser than peak bone mass, is considered osteoporotic. Measuring the bone mass is not 100% correlated with the fracture. WHO developed a method of fracture risk estimation. It's a software that's available on the internet. It's called FRAX. It gives the 10-year probability of hip fracture or a major osteoporotic fracture. The people may have high risk of fracture and have a good bone density. It's better to focus the treatment on the risk, not on the exact data extracted from the machine. To treat bisphosphonates are the choice to start. They're more widely used. Their efficacy is being approved, and FDA has approved alendronate, risodronate, etidronate, and zalendronate for the individuals who take glucocorticoids. Zalendronate or zalendronic acid is the intravenous form that's helpful in treating patients. We can use parathyroid hormone. Injection of parathyroid hormone helps stimulating the bones formation, and it's actually the only medication that has a positive effect on bone density. The previous medications the other medications in this field have decreased bone turnover. They decrease osteoclast activity and osteoblast activity. That means the balance of osteoclast activity and osteoblast activity is in favor of increasing bone density with decreasing the turnover of the bone. When you have decrease in the turnover of the bone, the quality of the bone declines. But PTH doesn't have this issue, and the quality of the bone produced by PTH is a very good quality. Vitamin D deficiency is increased because of increased prescription of sunscreen by dermatologists and decreased sun exposure. Beneficial of adding vitamin D and calcium in treatment of osteoporosis have been shown in few studies, but there's not a universal agreement about it. Not all of the studies have shown this benefit, but people should use the vitamin D and calcium Who should be treated? It's a difficult issue. American College of Rheumatology suggests -1 Z-score. Z-score means the T-score. T-score means the comparison of the 30-year-old with the patient. United Kingdom guidelines suggest -1.5 T-score. And Dutch guidelines suggest -2.5 guidelines. That means this difference reflects the difference of resources of the medical and financial status of the country, weakness of current evidence, and weakness of the studies, and it's overall it's recommended not to treat a patient according only to the T-score, the number that comes out of the machine. We must consider all of patients' clinical condition. FRAX has a consideration of steroids, but the FRAX uses low-dose steroids for evaluating. Only one box you can click. If patient takes more than 1 milligram prednisolone per day, FRAX is not good. FRAX is good for low-dose steroid, but you should consider that if you're using high-dose steroid, FRAX underestimates the risk. What is recommended? It depends on the patient. American College of Rheumatology wanted to revise the criteria of treating osteoporotic patients, but it didn't come out. I even checked it 2 days ago. It will come out, I think, at most 1 or 2 months later. But for now on, till present time, if patient has no fragility risk of fracture, a healthy young athlete, no treatment is necessary. If patient has childbearing potential and wants to have a baby, wants to become pregnant in the case of the woman, and uses 1 to 3 months of corticosteroids, no treatment, no consensus, no treatment proved studies present, and we can wait. Women and men over 50, women not wanting a child or non-childbearing age, and men over 50 with glucocorticoids for more than 1 to 3 months. If prednisolone more than 5 milligrams per day, alendronate or risodronate is suggested, and if prednisolone more than 7.5 milligrams per day, zoledronic acid is recommended. The problem is that this is a patient that goes to his rheumatologist or endocrinologist or primary care physician, has a bone densitometry, and they tell him everything is okay, but comes to you for pemphigus and needs a steroid. Prescribing prednisolone needs reassessment of previous plan. And if a patient is less than 50 months, 50 years, men, and non-childbearing women, glucocorticoid more than 3 months, tetrapride or PTH should be considered in addition to the other previous medications. Thank you for your attention. Any questions?
On those recommendations that you just gave, did they make any mention of duration of treatment and how it shows about the risks of atypical fracture and long-term therapy?
Specific for steroid-induced osteoporosis, we don't have enough information to answer your question. But if you ask about somebody
I already said I come from Mersin. Where is the Mersin? Mersin is located on north-southern Mediterranean Sea. What is the Behçet disease? Behçet disease is the first described Turkish dermatology professor Hulusi Behçet by 1937 as a triad of recurrent oral ulcers, recurrent genital ulcers, and uveitis. But during the ensuing years, multiple systemic associations such as articular, vascular, gastrointestinal, neurologic, and cardiopulmonary involvement have become increasingly apparent. I want to talk about epidemiology. Young individuals, especially 20 and 40 years of age, are most commonly affected. Male to female ratio is usually 1:1. Highest prevalences in countries along the ancient Silk Road. We already observed that male sex at a younger age of onset are associated with more severe disease. Ocular and central nervous system involvement are the basic prognostic factors in Behçet disease. Cardiovascular, pulmonary, and gastrointestinal system involvements are the major causes of mortality. We already observed oral genital aft and erythema nodosum were more frequent in females. However, papulopustular eruptions, thrombophlebitis, ocular, neurologic, pulmonary, and vascular involvement were more frequent in males. The etiology is still unknown, but various genes, especially HLA-B51, various microorganisms such as Streptococcus, herpes simplex virus infections, and the elevation Th1 and Th17 cytokines and lymphocytes have been suspected. We already observed that HLA-B51 and positivity and absence of HLA-B35 can be regarded as laboratory risk factors for vascular involvement. We already observed some genetic mutations such as factor V Leiden, prothrombin gene, platelet glycoprotein 1A polymorphism in vascular Behçet patients. Also, as oxidative stress genes, we already observed glutathione S transferase and acetyltransferase 2 and cytochrome P450 polymorphism in Behçet disease. Also, we already reported a patient, Behçet patients, triggering by imiquimod cream treatment, and we could decide that imiquimod cream could induce the genital and oral lesions via the induction of several cytokines. What about the clinical features? We can see oral ulcer, genital ulcers, erythema nodosum-like lesions, papulopustular lesions, superficial thrombophlebitis, paternitase positivity, and also we can see some other vasculitic skin lesions. As systemic manifestations, we can see uveitis, retinal vasculitis, arthritis, venous thrombosis, central nervous system involvement, gastrointestinal ulcers, pulmonary arterial aneurysm, also myocarditis, endomyocardial fibrosis, we can see as systemic manifestations. We already observed that male patients had vascular involvement about 5 times, neurologic and ocular involvement about 2 times more frequently than female patients. And also, we detected some bone mineral density abnormalities and cardiac complications in Behçet patients due to systemic treatment. The diagnosis of Behçet disease remains purely clinical. In 1990, the International Study Group for Behçet disease proposed diagnostic criteria: recurrent oral ulcers plus at least 2 of the other criteria, including ocular involvement, genital ulcers, erythematosum-like lesions, papillopustular eruptions, and pathology test positivity in the absence of an alternative clinical diagnosis. In differential diagnosis, the cause of oculomucocutaneous syndromes, including autoimmune Belo's disease, erythema multiforme, Reiter syndrome, seronegative arthropathies, sarcoidosis, Swiss syndrome, also herpes simplex infection, lichen planus, syphilis, systemic lupus erythematosus, ulcerative colitis, and mixed connective tissue disease should be excluded. Treatment of various symptoms of Behçet disease remains controversial because of heterogeneity of the condition, lack of reliable laboratory markers of the disease activity, and paucity of controlled clinical trials and unstandardized outcome measures for Behçet disease. In my speech, clinical studies were selected if they were randomized controlled trials, single or double blind, or interventions with pharmacological therapy compared to placebo or some other pharmacological agents. Colchicine has been used for the treatment of Behçet disease since 1975. The first double-blind study of colchicine was published in 1980. At 6 months, only patients with erythema nodosum-like lesions and arthralgias benefited from colchicine. Another randomized double-mask trial showed that colchicine was less effective than cyclosporine. In a recent trial, the effect of colchicine on the extraocular manifestations was investigated in a 2-year double-blind study. It was superior to placebo among women only. Each sex colchicine 1 to 2 milligrams per day was effective only for genital ulcers, erythematosum, and arthritis among women, but only for arthritis among men. We start colchicine therapy in every Behçet patients, and we believe that the low frequency of ocular and neurologic involvement in our patients may be a result of beneficial effective colchicine therapy. Azathioprine 2.5 milligram kilogram day decrease weight attacks and preserve visual acuity in a 2-year. Orogenital ulcers and arthritis also improved with azathioprine. Additionally, there was a tendency for preventing deep vein thrombosis. Azathioprine alone or in a combination with other immunosuppressive drugs provides substantial symptomatic relief and may prevent some major complications. The researchers suggested that azathioprine could be useful as a steroid-sparing drug. Early treatment with azathioprine also improves long-term prognosis of Behçet disease. Cyclosporine is usually the first-line agent in severe eye involvement like retinal vasculitis. Cyclosporine A, 10 milligram kilogram, reduced the ocular attacks and decreased mucocutaneous lesions. Cyclosporine was compared with conventional therapy in 4 studies. Improvement in the cyclosporine A treated group, particularly in uveitis, was shown in 4 studies. In 1 study, orogenital ulcers and arthritis improved more with conventional therapy than with cyclosporine A. In current clinical practice, the dose used is 3 to 5 milligram kilogram due to side effects. A blinded trial of cyclosporine A versus monthly bolus cyclophosphamide showed that visual acuity improved significantly in cyclosporine A group. In a randomized trial with topical cyclosporine and placebo, there were no difference in oral ulcer outcome. In a recent trial, the combination of cyclosporin A with colchicine was effective in reducing the number of uveitis attacks. As a result, cyclosporin A is the most rapidly acting drug for acute uveitis. The combination of cyclosporin A and with azathioprine gives a significantly better outcome in ocular disease. However, most patients develop a disease flare after drug discontinuation. Thalidomide, 100 mg daily was effective for reducing the number of oral ulcer and orogenital ulcers and papulopustular eruption in a 24-week study. Recurrence is usual when the drug is withdrawn. Low dosage of thalidomide has been found to be effective papulopustular eruption and orogenital ulcers. It's found to be useful also in Behçet disease, pyoderma gangrenosum, uveitis, and gastrointestinal ulcers. The usual oral dosage of the drug is between 100 to 300 mg day for 1 to 6 months. However, it's not recommended as a first-line therapy for mucocutaneous Behçet disease, especially in females. Among non-steroid anti-inflammatory drugs, the efficacy of the isopropanol 300 mg thrice in a day was no different for acute arthritis than for placebo in a controlled study. It provides only analgesia during the first week. Interferon alpha 2A subcutaneously 6 million international unit 3 times a week significantly decreased orogenital ulcers and papulopustular eruptions. In a randomized double-blind trial, topical interferon alpha 2C hydrogel was no beneficial for the oral ulcers. In open studies, interferon alpha achieved a partial or complete response in most patients with severe posterior uveitis. In uncontrolled studies, interferon is effective for both ocular and extraocular symptoms of Behçet disease, and long-lasting remissions have been reported after stopping the drug. Its high cost and frequent side effects limit its widespread use. Among anti-TNF agents, etanercept has been found to be effective on mucocutaneous Behçet disease in a randomized control trial. However, another study has indicated that no response is observed on mucocutaneous Behçet disease, which responded to infliximab afterward. High cost and side effects are still concerns with anti-TNF agents. There is also accumulating evidence with TNF-alpha blockers for other manifestations of Behçet disease, such as ocular, gastrointestinal, neurologic, and vascular Behçet disease that are resistant to conventional therapies. Infliximab 5 mg/kg was recommended as an add-on immunosuppressive therapy for patients who are intolerant or refractory to traditional immunosuppressive. In a control study, corticosteroid was tested, the efficacy of as the depot corticosteroid in mucocutaneous Behçet disease. It was useful for controlling erythematosus in females. Euler recommends early initiation of corticosteroid for the management of severe systemic manifestations. A 12-month randomized controlled trial has demonstrated that dapsone is associated with a significant improvement in mucocutaneous Behçet disease. What about the other drugs? Chlorambucil could be useful for ocular and neurological involvement. Cyclophosphamide could be useful for vascular and neurologic involvement. Methotrexate treatment could treat ocular and neurologic manifestation. Antibiotics such as benzathine penicillin, minocycline, azithromycin, and erythromycin could treat mucocutaneous lesions. Pentoxifylline could treat ocular and ischemic leg ulcers. Levomizole could treat orogenital ulcers, arthritis, and uveitis. Tacrolimus treatment could help ocular involvement. Mycophenolate mofetil could treat mucocutaneous and neurological involvement. We can select also granulocyte monocyte colony-stimulating factor for the treatment refractive genital ulcers as intralesional. Granulocyte and monocyte adsorption apheresis could help painful orogenital ulcers and ocular Behçet disease. Intravenous immunoglobulin could treat ocular involvement. Also, oral lactobacillus containing and low-dose natural human interferon lozenges could help oral ulcers. Pimecrolimus cream also could help mucocutaneous lesions, especially genital ulcers. Sometimes anticoagulation treatment will be necessary for venous thrombosis. Ripamycin can treat oral ulcers. We can use topical corticosteroid anesthetics, antimicrobial mouthwash, and sucralfate for mucocutaneous Behçet patients. Sometimes surgical intervention will be necessary for gastrointestinal ulcer perforation, also vascular aneurysm. We already reported a severe erythema nodosum due to Behçet disease responsive to erythromycin treatment. Recently, apremilast for Behçet syndrome was done, and apremilast was effective in treating oral ulcers in Behçet disease. What about the other biologics? Rituximab, gevokizumab, and canakinumab can treat ocular Behçet disease. There is one case report about anakinra. It will help orogenital ulcers, gastrointestinal involvement, and arthritis. Euler conclude uveitis, orogenital ulcers, and arthritis are mainly evidence-based in Behçet disease. The other organ involvements are based largely on expert opinions and uncontrolled evidence for open trials and observational studies. In our clinic, we selected as a first-line therapy for oral topical steroids, sometimes systemic steroids, anti-inflammatory instance, also topical anesthetics. In genital ulcers, we use as a first-line therapy topical steroid, sucralfate, oral colchicine, azathioprine, dapsone, and systemic steroids. For popular eruptions, we use as a first-line therapy topical steroids, oral colchicine, azathioprine, dapsone, and prednisolone. For erythema nodosum, we selected oral colchicine, dapsone, and systemic steroids for first-line therapy. And we decide for systemic involvement, we decide with the other department. As never, therapeutic options, alemtuzumab and hematopoietic stem cell transplantation are currently being investigated for Behçet disease. Thank you for your kind attention. I would like to invite our Congress next year, 16 and 20 March, in Istanbul. That's it.
Any questions?
presentation, no problems. In the web, about this onychomycosis with the laser treatment, this is only a little publication. All publication is about only ND-YAG long pulse. ND-YAG long pulse laser is specific for the problem for vascular problems, because the ND-YAG long pulse work in the red pigmentation is only for the oxyhemoglobin. The old publication thinks about the fungi. The most common fungi problem in onychomycosis is the rubrum, and this idea is for use the long pulse. The problem is long pulse is like a whiplash. If you shoot in your vein or in your hemangioma, it's very painful because the shoot is deep. The difference is when the laser quick switch and the YAG is more up superficially. This is difference. The idea, the difference companies to the laser is the most common rubrum produce xanthemoglobin and xanthopigment and say, okay, the laser long pulse is for the red color and the red color is the rubrum, but no is the truth, because to check difference publication, check the last, no, the transformation no is really, because only thing the pigmentation or the HUD. You check different publications about the long pulse, only long pulse, and the results, check this publication, the results is painful, very painful in all the patients, and you need differentiation, 2 sessions for 1 week, maybe 7 or 14 sessions. But in all the patients, the pain, and the pain. You see, you shoot in your nail is painful. What is the difference? Well, this group is from Greek. This group think not only is the color, is the HUD. In the check, you expose different microorganisms, fungi, for the grades on the HUD. And don't check the conclusion, no replique. Okay? Is the only, no is the color, no is the HUD. Check this study. This other study from group to Greek. This group change, okay? No long pulse, I use quick switch, okay? But this group say the color. Who the color? The color because the ND-YAG quick switch is for the tattoo remove, okay? For the different colors. But this group think, okay, I use the 2 points. Look at 164 and 532 spot, who is the same, the red color. When this group shoot with the second spot, remember the pain. Check the pain, because when you use for the color, you trace the nail and the shoot is of the blood, painful. Okay, this group, good results, but the problem is the pain. In our study, and don't use the cultures because the change in different studies, KWH and culture and biopsy is the similar results. Look at KWH and cultures is the same. In series and 3 is the same, KWH and cultures. Okay, in this study, this new research is onychoscopy. Onychoscopy is very interesting because in the patient you KOH and you use this and you have a 100 diagnosis to onychomycosis. Look at, it's very nice in the office to use the longitudinal strip and spikes. These 2 protocols is 100% to diagnostic to the onychomycosis. In our study, I use the quick switch. The quick switch with these parameters. Look at 200 passed, any age, diagnostic. This is the protocol. You should around all the night, 3 pass, vertical, horizontal, and use 2 different marks to the quick switch laser. Mona Lisa is from China, quick clear for USA, and only one session. 2 ASAR. Photography, Kawachi, onychoscopia, 1 session laser, and clinical revisions. Look at in the immediate results. Look at clear, and the pigmentation is developed. Look at, and the response. The nail cleans in probably 3 months, maybe 6 months. One session. Okay, look at 2 months. Pre-post, look at. Okay, the results, 200 patients, the child to old people. This is the toenails, fingernails. The response, 3 months, 6 months, 12 months, the segment. And the patients, pain, no problems, no change in the new nail. Discussion, this is finally this studio. The companies to the laser talk about the color, about the heart, about the difference. But this is the really. If you check the popcorn, it's very important. It's a phenomenon electroacoustic. When you shoot in the nail, it's very important where the fungi, the shoot is pa, pa, pa. If you no fungi, no listen nothing. Ta, 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 ta. When you come back to the fungi, pa, pa, pa. Popcorn is very nice. And in this moment, clear the sun, change the color. It's phenomenal electroacoustic. It's better check the practice because they listen and see the change. The conclusion is very effective, no problems, no effect adverse. It is for the old patient and diabetic, renal patients, and children's, for the old patients. This is the conclusion. The name is photothermolysis selective. It's a phenomenon de física cuántica. Física cuántica say all the atoms in the universe, the nucleus is positive. The around electrons may be positive or negative. The quick switch is like a linear particle accelerator. You shoot, and is the color and the hot and the power to the laser chain, because the long pulse is only 1 hertz, like a whiplash, and quick switch is like a full metal jacket, like a ametralladora. This is the important for change the nucleus to the fungi. Tomorrow, this study is only in vivo. Tomorrow, see the study in vitro, and you say who in the histological and mycological change the fungi, different fungi, not only superficial, not deep. But tomorrow, see this other study. Thank you.
Any questions?
I didn't get it. Do you have just one session for the name, or you have
Thank you. Good afternoon, and it's my honor to speak here on behalf of my supervisor, Dr. Jing. And I'm glad to share the topic to you, the pathogenetic and HPA axis regulated skin disorders, a new inspiration on related drug development. We all know that the skin is the largest organ of human beings, and it received all kinds of stressors outside the body. It may be communicate organ to between the outside and inside organs. So it's easier to be changed. And, but the clinical investigation shows the mental stressors or the psychological stressor can induce or aggressive skin disorders, such as vitiligo, psoriasis. All of these disorders is diagnosed easy, but cure intractable. Through this, maybe we can treat the skin as a window to accept the environment stress and to reflect the inside organs change. So the skin diseases are not isolated. Through the structure of the skin, there's including the nerve endings and the blood. So the skin may be changed by the nerve factors or the other kinds of factors through the blood to the skin. Here is a new name called, we call it for the skin, neuroimmunoendocrine organ. So the skin can be changed by the neural system, immune system, and the endocrine system. So, there's to exist an axis. We call it HPE axis. Here shows the work of the stresses outside. When stress on the brain, and it can increase the CRF. The CRF can be transferred to the pituitary to combine to the CRF receptor 1. Then it can secrete more ACTH. And ACTH can be transferred through the blood vessel to the adrenal and binding to the MC2 receptor. The result is the high level of the cortisol. But there exists negative feedback. It can work on the level of the PMC and the. So where's the laser pin?
That's the one right there, top button.
Okay, thank you. It can both work on the CRF and PMC and the CRF to decrease the concentration of them. So there's exit homeostasis to make the steady condition. This is the what do we think? Maybe there exists another regulation in the skin. So the skin cells and the mast cells, the immune cells and nerve endings, they may be including the cycle like the HP axis to regulate the skin with the stressors, maybe UV. So what will happen with the stressors from the mental is our first question. So we designed the part 1 to investigate whether the mental stress is able to regulate the function of skin. So here's including 2 kinds of models, which is a depressed models. The CIS and the CMS both can cause the depression. The first is the behavior. The open field test, tail suspension test, and the full swimming test. All of them shows the stress from the mental can cause a depressed-like behavior. And this is the structure of the hippocampal. It shows the cells in both CA1 and DG area. The cells is fewer and the structure is loosened. This shows the corticosterone level in the serum. It shows the CIS and CUMS can cause the higher level in the serum of the corticosterone. It's higher. So after that, we investigate the pigment in the skin. So both of the CIS and the CUMS can cause the skin become whitely than the control group. This is a hair follicular, and also the CIS can cause and the CUMS can induce the follicular fever and the melanisome fever. So we want to suggest a new gas here. Maybe there's a lack HPA exit in skin. So the key factors and the receptors are expressed in skin HPA axis. So the CIH can be bound to the CIHR and increase the PUMC level. The PUMC first can be transferred to the alpha MSH and combined to the 1 receptor. And it is increased melanogenesis. The second transfer is transfer to the ACTH, binding to the MC2R receptor, and it also can increase the melanogenesis. So after that, the ACTH can be transmitted to the glucocorticoid, and it has like negative feedback, and to decrease the level of the PUMC and the CIH, which like the central HP axis. So when the UVR work on the skin, just like the stressor, and it can enhance the melanogenesis so our skin become much darker. So based on this, we check the expression of key hormone in the skin, and it shows the effect of the stress. All of the key hormone of the HP axis is much lower. So it shows the effect of stress is inhibit the skin HPA axis. And what is the stress on the skin compared to the UV stimulate? So here we do the first HP axis. The first shows in the control group, the UV can decrease the CIH and the PUMC's level. But in the CUMS group, this effect is lower. So we can guess that the stress can make the lower reaction to the UV. It means the HPA axis in skin is weaker. After that, we study the key proteins of pigment system. It shows the MITF and the TYR, which are both the very important protein for the melanogenesis. Also, in the control group, the protein expressed is much higher when we give the UV. But in the CUMS group, the UV cannot change the expression of the two proteins. So it probably means the weak protection for our skin. So as I said before, that maybe it's induced or aggressive skin disease is caused by this reason. So the summary for first part, the CUS and CUMS, both of the depressed model can make the central HP axis is in a hyper functional condition. But in contrast, the skin HP axis will become to hypo functional condition. It's in contrast. We guess it's maybe induced by the GC because the GC is a result for the central HP axis and maybe a reason for the reduce of the skin HP axis. So the part 2, we study the role of skin HPA axis in the regulation of skin. We did both in vitro and in vivo. In vitro, we introduced the DEX and alpha message, and in vivo we used here the IU486 is an inhibitor of GC receptor. The first part in vitro is the GR indeed expressed in the cell, and we studied the expression of the key proteins for the melanogenesis. Yes, the proteins level is higher. So, and after that, we study the dendritics in a normal human cells. It shows the alpha message and the DEX both increased the dendritic number and dendritic length. So it promotes the dendritic. And we also study the NHEM migration. So the DEX can increase the migration in the cell, in vitro. So after that, we study in vivo for the C57 mouse. It shows the cortisone can increase, can make the mice whiter. So we can see here, the mice is whiter. After that, we use the CUMS model. The CUMS model is like the cortisone result. The white is whiter. But after that, we add the RU486 here with the CUMS model, and we can show the mice is darker than the only CUMS group. So it suggests that the RU486 recovers skin color partly. After that, we study the expression of key proteins in skin melanogenesis. Same, the CUMS can inhibit the protein expression, but when we added the RU486, it is much higher, so it recovers the pigment function. Then we study the key factors in skin HPA axis for the CIH, PUMC, and the CYP11A1, the MRA expression. It shows also the same result. The CUMS decreased all of the concentration of the expression, but when we add the GC receptor inhibitor, it shows much higher. So the RU486 maybe recovers the skin HPA axis. Here is previously showed the central HPA axis, and here is the skin HPA axis we thought. So the GC maybe connect both of them. When the chronic stress working on the brain, it will cause the high level of GC, and the high level of GC can inhibit the skin HPA axis. So the skin cannot be reaction at the normal level. So when the UVR work on the skin will not change as normal. So what is pathology can support? Maybe we can find the mechanism, and we know that effects on skin functions by the mental stress. We focus on the role of GC. For that, we can do the innovative drug and focus on the GC as a target for the new drugs. So here I shows the use for drugs for treat many skin diseases. It's used for many clinical, but it shows some contracts to the expectation. So we should think more of the drugs we're using now is all the hormonal drugs. So part 3, the drug discovery, we use the in vivo model to show this HPA axis may work on. So the drug's name is HZCZ. HZCZ can increase the HPA axis both in CIH, PUMC, and CPY11A1, and it shows significant difference when we give the CUMS the drugs. But you can see here, when we use the CUMS model, the HCZZ can increase the change of the UV. So it is, we can think maybe it's, this drug can recover the skin HP axis. After that, we shows the drugs HCZZ can inhibit the GC level in the serum. So it's much lower than the CUMS group. So here is the study on the pigment with the drug. So the CUMS increased, make the mouse whiter, but we can see here the mouse is darker than only CUMS group. So maybe the drug can promote the skin pigment, which maybe a recover to protect our skin. Last shows is the effect of the drugs on the melanogenesis proteins, also the protein expression. It shows the drug can increase the protein expression in the skin, and also can make a more significant difference when we give the UV to the mice. So it can increase the melanogenesis and promote the skin pigment. Here is what we used the skin HP axis for the drug discovery. Here's the prospects for our study. So many drugs we used for its hormonal drugs. It can increase the GC result in the inhibition of the skin HP axis activity. Here we shows maybe it have made bad effects on the skins. After that, the mental stress inhibits the initial of a skin HP axis. So based on this, we try drugs. Maybe it work on the GC and it can release the inhibition for mental stress on the skin HP axis. Okay, what we did is just to think maybe it's more diseases caused by the psychological stressors. Maybe we want to, just like me, I want to finish more work and do better experiments. And maybe I found my hair is fewer and fewer. So it's a new inspiration on more drug screening in the future. It's our group and in our university campus. Thank you very much.
Any questions?
How you measure the darkness of the skin? So you quantify it, right?
Yeah.
So how did you do it?
Yeah, we use a scan.
Okay. Hello, everyone. I'm Arpia Vetisyan, and I'm a research associate in Nairian, a company that develops and manufactures all natural cosmetics. Today I will talk about the paper pertaining the chemical composition and biological activities of the essential oils of Ocimum basilicum purpureum, Ocimum basilicum tharsiflora, and Ocimum citradorum. All species were grown on the same high altitude field in Armenia, and the corresponding essential oils were extracted by Nairian's staff on our facilities. This work has been done in collaboration with our colleagues from Yerevan State University. So, what is Nairian? Nairian is a company that creates 100% natural premium beauty products extensively using essential oils and other natural ingredients locally sourced from Armenian highlands. The company has its own essential oil extraction facilities, and it grows different herbs for the production of essential oils and herb extracts. Both the facilities and the factory are situated in the 1,600 meter above sea level, and we distill different essential oils such as basil, melissa, mint, rose, tarragon, and many others. Many research studies on essential oils show that most of them have great antibacterial, antifungal, and antioxidant properties, and therefore could be particularly useful for the prevention and treatment for diverse dermatological disorders such as psoriasis, eczema, acne, etc. One of such disorders is hyperpigmentation, a darkening of an area of skin or nails caused by increased amount of melanin. The production of melanin in human skin, melanogenesis, is a combination of enzymatically catalyzed chemical reactions. The key enzyme, tyrosinase, is catalyzed by tyrosinase enzyme. It can catalyze the first and only rate-limiting steps of the melanogenesis. And the suppression of enzyme activity is the most reported method for the inhibition of melanogenesis. Because the hyperpigmentation is a cosmetically important issue for all over the world, researchers constantly seek potent but at the same time safe inhibitors for melanogenesis. The most famous skin whitening agents nowadays are corticosteroids, retinoids, kojic acid, and arbutin. These all agents have really very effective effects, but unfortunately there have been reported some undesirable side effects caused with them, especially in the case of prolonged usage. So the aim of this study to investigate the chemical composition of these three different types of basil essential oils cultivated in Armenia, paying special attention to the antioxidant properties and tyrosinase inhibition ability of given oils. Why basil? Firstly, basil belongs to the family of Lamiaceae. It grows in several regions around the world, and it has been known from ancient times. It is widely used in medicine and food industry. It is relatively easy cultivated herb, and it has several crops per year in Armenian conditions. This research was conducted according to this scheme. Firstly, essential oils were distilled from all these types of basil. After that, the chemical composition of each essential oil was explored by GCMS analysis. Also, antioxidant, tyrosinase inhibitory, antibacterial, and antifungal properties were measured. Essential oils were obtained by distillation with cloaca type apparatus Plant material was hydrodistilled for 3 hours, and then the oil has been dried with sodium sulfate and stored until 4 degrees per Celsius. Here you can see the yield of essential oils. For instance, 0.12% for purpureum, 0.40% for citroderum, and the highest level is 0.24 for Tharciflora. The main chemical components of the essential oils were explored using the GCMS analysis are shown in this graphic. As you can see, the main components are linalool, methylchavicol, citral, and nerol. The chemical composition of these 3 types of essential oils are quite different from each other. For instance, the Ocimum Tharciflora contains approximately 68% of linalool, which is methyl alcohol, and methylchavicol about 18%, which is phenyl propane. While in the case of Basilicum purpureum, the percentage of these components is reversed. And for the citroderum, we can see that it contains the nerol and also the citral, which is a kind of aldehyde. According to some studies, such as Mohammad Al-Mamari et al. 2011, essential oils of the plants rich in terpene alcohols, phenylpropanes, terpene aldehydes, may influence the process of melanogenesis in human skin. So we decided to analyze the antioxidant and tyrosinase inhibition properties of these essential oils. The antioxidant activities of these 3 essential oils were measured through diphenylpicrine-hydrazine (DPPH) assays, and the data was using Genesis UVB spectrometer. At the concentration of 100 microgram milliliter, the IC50 value of Ocimum basilicum tharciflora was equal to the control sample grapefruit seed extract, and it showed the highest level of antioxidant activity. Also, the tyrosinase inhibitory activities of these essential oils were measured using the same spectrometer. And here also you can see that Basilicum tharciflora is the one to show the highest level of inhibition. It has approximately 20% of enzyme suppression rate, and at the 100 microgram milliliter concentrations. The results are shown with plus-minus standard deviations. In addition to these previous experiments, the microbiological assays were performed to determine the minimal inhibition concentrations for each essential oils. Here are shown the antibacterial activities of the 3 different oils, influence of the microorganisms E. coli and Staphylococcus aureus, with positive control and negative control, and with different dilutions, concentrations of essential oils. After that, the minimal inhibition concentrations were calculated, and I would like to direct your attention to these 2 bacteria, Staphylococcus aureus and Pseudomonas aeruginosa, which are the bacteria that exacerbate the secondary local inflammatory acne response. The antifungal properties of these 3 essential oils were measured using the same agar diffusion method. Also, in this case, minimal inhibition concentrations were measured. Finally, after these experiments, we came to the conclusions and make a plan for our future work. From all 3 basil species cultivated in Armenia, the Ocimum tharciflora shows the highest level of antioxidant and antibiological and tyrosinase inhibitory activities. Based on such results, we found that it might be advisable to use this essential oil in topical applications to prevent the skin hyperpigmentation. Even though it shows relatively mild tyrosinase inhibition ability, it still has the highest level of antioxidant activity, which can slow down the process of melanogenesis and reduce hyperpigmentation, especially again in the case of prolonged usage. Also, Osmium basilicum thyrosiflora should be further investigated for our anti-acne topical preparations. It is very interesting to investigate the use of mixtures of these essential oils with others, potential with tyrosinase inhibition abilities, to see if such synergy will yield better results for such problems. And now we have created an experimental formula for a brightening cream in which we use these essential oils, such as basic components, and to address hyperpigmentation. And of course, we created it based on the dermal maximums from Tisserand's books on safety of essential oils. And currently, the text is in process, and we are doing the in vivo testing on our volunteers. I would like to thank you, my colleagues from State University and Narayan, and thank you too. I will be happy to answer your questions.
Thank you very much for your speech. Our next speaker will be
Hello, dear colleagues. I try to explain acne and treatment. Epidemiology, acne is an almost universal disease. Acne's prevalence peaks between age and the start of the third decade. In a survey of 48,665 employees in Germany, the overall prevalence of acne was 4.2%. In the sub-analysis, the prevalence on the age group 16 to 20 years was 24.8%. Up to 40% of women over 25 years of age still have acne. A prevalence of late-type acne, especially in patients with a genetic predisposition, to be as high as 50 to 53%. Etiology, hormonal function, especially DHEAC, increased sebum production, follicular hyperkeratinization, proliferation of Propionibacterium acnes, various cascades of inflammation. Severity. The severity of acne in adolescence is associated with a positive history of severe acne in first-degree relatives, especially the mother. Many inflammatory pathways and factors are involved in acne pathogenesis. However, the initial inciting stimulus has not been identified. Propionibacterium acnes, several inflammatory mediators, cytokines, defenses, peptidases, serum lipids, and neuropeptides. Yes, modern aspects of the pathogenesis of acne. Androgens, especially dihydroxyepandrosterone sulfate, play an important role in the early pathogenesis of acne, leading to larger sebaceous glands with increased sebum production. In addition, androgens stimulate the keratinocytes of the sebaceous duct and infundibulum. Excessive androgen production leads to increased sebum production and acne of varying severity. Skin not responsive to androgens produces no sebum and develops no acne. Lipid synthesis requires androgens and peroxisome promoter activated receptors. Yes. Neuropeptides can control the development of clinical inflammation in acne. Substance P can be identified in numerous immune-reactive nerve fibers of acne skin, and sebaceous glands respond to it with the synthesis of the inactivating neutral endopeptidase. Synthesis of chemokines and cytokines by keratinocytes can be stimulated by certain Propionibacterium acnes strains through the activation of Torac receptor 2. Yes, you see serum lipids induce Torac receptor 2, Propionibacterium acnes, protease activated receptor 2, and Torac receptor, PPAR, peroxisome prefertor activated receptor, induces cytokines, defensins induces cytokines, and stress induces pro-inflammatory neuropeptides, and peptidases induce immunocompetent cells. Yes. Inflammatory events during acne lesion development increase the expression and bioactivity of pro-inflammatory mediators. Upregulation of inflammatory mediators in uninvolved skin and early lesions. E-selectin, vascular adhesion molecule 1, interleukin 1, integrin, interleukin 1 alpha bioactivity in open comedones, upregulation of defensin 2 immunoreactivity, elevation of CD3 plus and CD4 plus T cells and macrophages in uninvolved skin. Peptidases, expression of pro-inflammatory peptidases on sebocytes and keratinocytes. Inhibition of peptidase activity leads to an anti-inflammatory profile. Neuropeptides, upregulation of neuropeptides in uninvolved skin via corticotropin-releasing hormone, melanocortin-1 receptor, substance P. Torac receptors. Activation by Propionibacterium acnes triggers inflammatory cytokine responses. P. acnes is present in sebaceous follicles undergoing comedogenesis and may play a role in comedo formation. Activation by endogenous ligands. Changes in lipid biosynthesis. Confirmed association between sebaceous lipid synthesis and inflammation. Peroxidated lipids trigger inflammatory responses. Clinical trials. The anti-inflammatory dapsone is effective in treatment of non-inflammatory lesions. Dapsone has multiple anti-inflammatory properties. Retinoids are effective in treating non-inflammatory lesions. Retinoids downregulate Torac receptor 2 and interleukin 10 expression. Chronic course. Acne is not a short-term illness, but instead shows a chronic course with persistence over years. Acne is chronic disease using the WHO criteria. Acne compared with another chronic disease, atopic dermatitis, major feature, duration, genetic background, age of onset, spontaneous remission, recurrences, follow-up, therapy, social counseling, physiological counseling, scarring. Exacerbating factors of acne: diet, menstruation, sweating, personal stress, ultraviolet radiation, application of pomades, and occupation. Hyperinsulinemia. The relationship between hyperinsulinemia and elevated IGF-1 and reduced IGF binding protein has been increasingly supported by controlled case studies. Smoking. The relationship between the number of cigarettes smoked daily and the severity of acne is controversial. Diet and acne. Relates to hormones. As milk is meant to increase the growth of cows, it naturally contains growth hormones and anabolic steroids. Relates to carbohydrate. Content of dairy products with related effects on serum insulin and insulin-like growth factor 1. The Western diet has also been researched as a potential cause of acne. Low glycemic load diet, improvement of acne, improvement in insulin sensitivity, a reduction in testosterone availability, and a decrease in adrenal androgens. Therapeutic agents of acne, inhibition of inflammatory cascades, reduction of follicular hyperkeratinization, suppression of the effects of androgens. Yes, you see, choice of treatment according to lesion types, comedonal lesions, mixed comedonal lesions, and papulopustules, stick lesions. Comedonal lesions prescribe one of the following topical retinoid, benzoyl peroxide, salicylic acid, azelaic acid. If results are unsatisfactory, increase strength or change medication. Mixed comedonal lesions and papulopustules, retinoid plus topical antibiotic, or retinoid plus benzoyl peroxide, or retinoid plus benzoyl peroxide plus topical antibiotic. If results are unsatisfactory, prescribe retinoid plus course of oral antibiotic. Stick lesions, you see, from Christine et al. European SH guideline for acne therapy. Based on these guidelines, topical monotherapy with antibiotics is not recommended. Instead, topical combination therapy with BPO is recommended for mild papulopustular acne. Topical retinoids are recommended as monotherapy for comedonal acne or in combination with BPO or topical antibiotics for milder papulopustular acne. Topical azelaic acid therapy is the second line recommendation for comedonal and mild papulopustular acne. Topical corticosteroids shouldn't be used in treating acne. Combination therapy with topical drugs and oral antibiotics is recommended for moderate to severe acne, as well as less severe inflammatory acne which fails to respond to topical therapy alone. The systemic antibiotics shouldn't be used alone, but instead in combination with topical retinoids, BP or azelaic acid. For women, oral contraceptives containing anti-androgens are another option. The recommended antibiotics dosages are doxycycline 50 mg daily BID, 200 mg BID, minocycline 50 mg BID, tetracycline 500 mg BID, and erythromycin 500 BID. Therapy can be continued for 3 months. Yes, you see non-traditional treatment options for acne vulgaris, chemical peels, photopneumatic therapy, isolase, light, laser, and photodynamic therapy. Chemical peels mild severe acne lesions and or oily skin type, glycolic acid or salicylic acid. Side effects of topical acne therapy: erythema, stinging, burning, desquamation, cirrhosis, bacterial resistance. Tretinoin, isotretinoin, adapalene, azelaic acid, benzoyl peroxide, erythromycin, clindamycin. Severe acne requires systemic treatment. We use oral antibiotics, hormonal anti-androgens, systemic isotretinoin. Systemic combination therapy, topical and systemic combination therapy with oral antibiotics is recommended for moderately severe inflammatory acne as standard therapy. It should only be used for milder inflammatory acne that fails to respond to topical therapy. Side effects of systemic antibiotics commonly used to treat acne. Gastrointestinal symptoms, vaginal candidiasis, esophagitis, phototoxicity, hyperpigmentation, drug-induced lupus erythematosus, cholestatic hepatitis, pancreatitis, pseudomembranous colitis, acanthaemia, headache. Tetracycline, doxycycline, minocycline, erythromycin, UC. Hormonal anti-androgen therapy is not recommended as a first-line monotherapy for uncomplicated acne. Ethyl estradiol in combination with cyproterone acetate, chlormadienone acetate, dienogest or drospirenone is recommended only as a combination therapy for women with moderate papulopustular acne to conglobate acne. Therapy with oral isotretinoin. Isotretinoin is without question the most effective oral agent for severe acne. Efficacy of isotretinoin therapy for severe acne. You see level of evidence, different years. Dermatologists in private practice and other physicians are in a position of conflict since the publication of the European S3 guidelines, as this document once again recommends isotretinoin as the drug of choice for severe acne. The feeling is that the sooner isotretinoin is employed for acne with marked inflammation and a tendency to early scarring, the better it is for the patient. The recommended doses are 0.3 to 0.5 milligram per kilogram body weight. For severe papulopustular nodular acne, more than 0.5 milligram per kilogram body weight for conglobate acne. Therapy should be continued for 6 months, sometimes even longer. And as isotretinoin regimen of 0.15 to 0.40 milligram kilogram 1 per day revealed similar therapeutic results to treatment with 0.5 to 1 milligram per kilogram 1 per day, but with a lower rate of side effects. On the other hand, personalizing treatments by starting with a low dose 0.1 to 0.2 milligram kilogram 1 per day and identifying the highest dose tolerated by the patient may clear acne with acceptable side effects and keep the duration of treatment short with low relapse rates. Yes, Rao et al. Reported their studies prospective non-comparative study. 50 participants, both male and female, treated with isotretinoin at a dose of 20 milligram per day. Relapse occurred in 4% of the participants over a 6-month follow-up period. Their conclusion that 3 months of treatment with low-dose isotretinoin was found to be effective in the treatment of moderate to severe acne vulgaris with a low incidence of serious side effects. This dose also was more economical than higher doses. Another study, Abbas et al. Reported Low-dose isotretinoin was found to be a safe and effective choice for patients with moderate to severe scar-prone acne vulgaris. Length of remission following isotretinoin. About 20 to 30% of patients experience a recurrence after 1 year. Age and dose are important factors. Relapse of acne vulgaris related less to the cumulative dose and more to the length of sebaceous gland suppression, macrocomedonal pattern of acne, smoking, age, younger, under 14 years and over 25 years. The pharmaceutical quality of generic isotretinoin products. The pharmaceutical quality of generic isotretinoin products can be questionable. Among 14 generic isotretinoin products tested, 13 were not compliant with 1 or 2 pharmaceutical parameters, and 11 were not compliant with 3 or more parameters. Possible consequences of this could be reduced activity or unexpected side effects. A new isotretinoin formulation, isotretinoin Lidos, using lipid encapsulation technology was registered in 2012. Greater gastrointestinal absorption, the mean plasma level of isotretinoin Lidos is higher compared with the standard isotretinoin. Isotretinoin Lidos is not inferior to standard isotretinoin regarding efficacy. Side effects of isotretinoin: cheilitis and cirrhosis, increase of blood lipid teratogenicity, induction of depression and suicidal ideation, inflammatory colitis, but not Crohn's disease, rhabdomyolysis, ocular symptoms, decreased dark adaptation, decreased vision, abnormal meibomian gland secretion, and blepharoconjunctivitis. Yes, risk of suicide. In addition to the risk of teratogenicity with systemic retinoid therapy, one must pay careful attention to the possible induction of depression and suicidal ideation. Systemic corticosteroids. Systemic corticosteroids can be administered orally to treat severe inflammatory acne, acne fulminans, and acne due to stimulated hypothalamus pituitary adrenal axis. Female patients with stimulated hypothalamus pituitary adrenal axis and functional adrenal hyperplasia due to chronic stress can be treated with low-dose oral prednisolone, 2.5 to 7.5 milligram per day for a period of 1 to 2 months. Dapsone, anti-inflammatory agent, inhibits the release of interleukin 8 from human cultured keratinocytes, prevent lipid peroxidation, neutrophil recruitment. New developments, xylitol, 5-lipoxygenase inhibitor, is decrease leukotriene B4, decrease the acne severity index, decrease the total sebum lipids, normalization of the causal skin surface lipids. Atrophic acne scarring. Treatment: in the treatment, dermabrasion, subcision, skin needling, punch techniques, chemical pills, and the cross technique, tissue augmentation, fat transfer, autologous fibroblast transfer, laser resurfacing. Management of, Management of acne scars during treatment with concomitant isotretinoin. UNAIDS all reported successful treatment of acne scars using the 1550 nanometer erbium doped fiber laser in 35 patients taking isotretinoin. Acne scars can be treated more effectively by concomitant use of an infrared fractional laser with low dose isotretinoin. Otherwise, there are potential legal repercussions should resurfacing treatment during isotretinoin therapy lead to complications. Thus, such treatment warrants caution, particularly for less experienced practitioners. Yes, this study, 1550 nanometer erbium doped fiber laser, 35 patients with acne scarring, isotretinoin 10 milligram per day for more than 1 month prior to the commencement of the fractional laser treatment. Conclusion: acne and acne scars can be treated more effectively by concomitant use of an infrared fractional laser with low dose isotretinoin with reduced microthermal damage zone densities. Yes, conclusions. Oral isotretinoin monotherapy is strongly recommended for the treatment of severe acne, despite a range of possible serious adverse events that must be considered. It has to be administered under contraceptive protection in female patients. The pharmaceutical quality of generic isotretinoin products and the obtainability of isotretinoin through e-pharmacies add new, important practical issues to be aware of. Oral antibiotics in combination with azelaic acid can also be recommended for the treatment of severe acne. Oral antibiotics in combination with hormonal anti-androgens, topical adapalene, and or benzoyl peroxide can also be considered for the treatment of severe acne in female patients. Future anti-inflammatory systemic compounds such as the 5-lipoxygenase inhibitor xylitol could substitute systemic and topical antibiotics which induce bacterial antimicrobial resistance. Yes. Our patients who received isotretinoin before, after, similarly before, after treatment. Thank you.
Thank you very much for your informative lecture. Any questions? The next speaker will be
Dear Chairman and colleagues, today I would like to present you off-label uses of vitamin D treatment in dermatology as review. Vitamin D was discovered first time in 1922, and most important functions of vitamin D are bone mineralization, absorption of calcium from intestine, and prevention of rickets. It's known as vitamin D3 from animal origin, and it's synthesized from 7-dehydrocholesterol by action UVB on the skin. And active vitamin D occurs by hydroxylation in liver and kidney. And then active vitamin D binds serum proteins and reach target tissue. And target tissue has vitamin D receptor gene. Vitamin D has 3 analogs for topical form. as topical form that are called tocilstol, calcipotriol, and mexicalcitrol. They have been found effective in psoriasis because of inhibiting the proliferation and regulating the differentiation of keratinocytes. And many skin diseases have a similar pathogenesis with psoriasis, and in this presentation, using of vitamin D in skin disease other than psoriasis is demonstrated. First of them is vitiligo. In vitiligo, 4 randomized control studies were determined. In 2 studies, PUVA treatment and PUVA calcipotriol combined therapy were compared. Calcipotriol was applied one side of the body of vitiligo patients who treated with PUVA. And as a result, at the end of the study, combined therapy given site was improved completely in most of the patients. And the other one, calcipotriol, betamethasone dipropionate, and combined therapy were compared in 49 vitiligo patients. And proportion of healed patients were 6%, 13%, and 26%. Tocilstol and tocilstol narrowband UVB combined therapy were compared in another randomized control study, and combined therapy given site shows significantly higher repigmentation than the other side. And in this picture, left elbow treatment with tocilstol and narrowband UVB, and right elbow narrowband UVB alone. And as you can see in the table, there are many studies, comparative and uncontrolled studies about vitamin D treatment in vitiligo. Some of them it's effective, some of them are non-effective. And keratinization disorders. 1 randomized control study was detected. 67 patients with various keratinization disorders were treated with calcipotriol ointment twice a day during 12 weeks. Especially patients with ichthyosis improved significantly. And there are many case reports in literature, such as porokeratosis, Derrier disease, Grover disease, and tumoral disorders. In a comparative study, calcipotriol and tretinoin cream were compared in 40 patients with oral leukoplakia. And 5 weeks later, 2 treatments were shown similar efficacy. And 80% of patients were improved completely in both groups. And the other one, calcipotriol was given 2 patients in 2 case reports. One of them was a 13-year-old girl with nevus comedonicus, and the other one, 69-year-old woman with epidermodysplasia verruciformis. And 6 months later, both of lesions were regressed significantly. In this picture, lesion of patients with epidermodysplasia verruciformis and after treatment. And also there are some case reports about acanthoma, Bowen disease, and sclerodermoid disease. In an uncontrolled study, 3 patients with scleroderma were treated with oral calcitriol, and 6 months later, clinical improvement was detected. And in 2 uncontrolled studies, calcipotriol treatment was given patients with morphia. At the end of the studies, lesions improved significantly. In these pictures, you can see morphia lesions before and after treatment. Before treatment, atrophic telangiectatic plaques on the left arm, and after 3 months of treatment, plaque regression and slight pigmentation. And the other studies. And let's talk about the other disease. And first of them, I'm going to start with prurigo nodularis. In a randomized control study, 10 patients with prurigo nodularis who didn't benefit from topical corticosteroid were treated with calcipotriol. And 8 weeks later, size and numbers of nodules decreased markedly than betamethasone. And the other one, polymorphic light eruption. In a randomized control study, 13 patients were treated with calcipotriol or placebo on their 2 symmetrical array. Photoprovocation tests were given to the patients. At the end of the study, calcipotriol given areas lesions dependent with polymorphic light eruption regressed significantly. Atopic dermatitis. In another randomized control study, 107 children with winter-related atopic dermatitis were treated oral vitamin D once a day for 1 month. And 1 month later, there was a clinical improvement significantly. And there is a lot of disease, dermatological disease about vitamin D treatment. Erythema centrifugum, viral warts, xerosis, Hailey-Hailey disease. Viral wart before and 4 months later from treatment. And in this picture, Hailey-Hailey disease before and after 3 months treatment with tocilstol. Vitamin D is given to patients with psoriasis because of inhibiting proliferation, stimulating differentiation of keratinocytes. Also, vitamin D stimulates melanocytes and melanin synthesis. So, it was shown in various randomized control studies that vitamin D analogs highly effective combination therapy in vitiligo, but it's not effective to treat vitiligo patients with only vitamin D analogs. In a lot of skin disease, topical vitamin D can be useful like psoriasis because of regulating keratinocytes. But vitamin D can be also given in other skin disease due to effect with other mechanisms. Some examples of those mechanisms are in xerosis, increasing filaggrin expression; in Hailey-Hailey disease, inhibiting acantholysis by transactivated integrin gene; in sclerodermoid disease, inhibiting proliferation of fibroblasts. As a result, vitamin D can be useful in a lot of skin disease other than psoriasis because of various mechanisms of effect, but it still required more and comprehensive study about using vitamin D in various skin disease. Most of studies are as case reports. And thank you for your kind attention.
Any questions? Thank you very much for your informative speech. I think we have come to the end of today's session.